So I have two talks at this conference. I will talk about data and AI for better health, and more an introductory talk, which hopefully will resonate with a wide audience. And tomorrow I'll talk more about data and sharing data on a global scale. We do have some disclosures, which I'll have here. So let me first start with the rationale of AI and health data. Why do we want this, right? I hate it when technology just comes to us and we didn't think about, okay, why do we want this? So we did think about this. And it starts with a very simple test that we did in my country, in the Netherlands, in Maastricht, with our physicians. We asked our physicians, you have now seen this patient, so they had an intake conversation with lung cancer patients. And we asked them a very simple question. What is the chance that this patient will be alive 2 years from now? And when you ask doctor that question, so they would say some patients are quite likely to survive and other patients less likely. And so what you're doing in such an experiment is that you're putting an order to the patients in terms of the likelihood to survive, the prediction of that. And if you, after 2 years, because we're predicting 2 years survival, know the answer, you can put a metric on the quality of that prediction. So you can say, well, if you are a perfect predictor of outcome, you would have ordered your patient like on the top. You have an error in a curve of 1, it will come back, I'm sure in this conference, but in my talk for certainly. You have found a doctor that can perfectly predict when somebody will die or not, right? If somebody will be alive 2 years from now. If you would be very bad at this, it would look like the bottom. The error in the curve would be 0.5, so the doctor really can't predict who will be alive or not. And 0.72 is in the middle. You can see some wild predictions there. Now, we did this experiment in my hospital in Maastricht, and we found out quite a long time ago, this was about 15 years ago, that doctors had an error in the curve of 0.56, meaning they are extremely close to random. It means that if you come into my hospital and you, as a patient, as a lung cancer patient, and you ask to our physicians, will I be alive 2 years from now? The answer that you're getting back from our physicians is just as good as tossing a coin. It also was tested, this was a prospective test in 5 doctors. One of the doctors had 25 years of experience, one of the doctors had 1 year of experience. It didn't matter. They were equally bad at predicting outcomes. And you might wonder why that is, right? One of the reasons is that doctors are humans, and humans are limited. When you take any decision in life, whether it is what you will cook tonight, or where you go on your next holiday, or whether or not this patient will be alive or not, you can only take 5 things into your mind when you make such a decision. Right? That's the limit of human cognitive capacity. So you can see on the bottom, let's see if I can get my pointer. Sorry. The limit of human cognitive capacity is 5. Right? Any time more than 5 factors are involved, humans cannot do it. But of course, when we predict outcomes of treatments, there are many more factors to consider. So that's a problem. It's not a human task to predict this. The second thing is you have to decide and predict a lot, right? There's so many therapies and so many differences between patients that it's actually, you have to predict quite a bit, which is hard. Then you might say, well, I'll just read the literature, right? But the problem is, as physicians or as care professionals, you can't read the literature. If you want to read the literature on lung cancer, you have to read about 10 hours every day, every single day of the year. Right? You don't have time to see patients then. And what's in literature is extremely biased, right? Especially for India. Typically, literature is produced by the US or by Europe, and that may not be applicable to India, and I have some examples of that. And many times we introduce things simply because they're better, right? Why would you buy the new CT scanner from Philips? Because it's the new CT scanner from Philips and it gives better pictures, right? But you don't know how that relates to outcomes, right? And the British Medical Journal did an overview about what is the evidence base that we have in medicine. The evidence base that we have in medicine is about this. In 1/3 of the things we do in medicine, we know we have randomized clinical trial evidence that they work. In 1/6 of the things we do in medicine, we have evidence that they do not work, these treatments, but we do them nonetheless. And in about half of things we do in medicine, we don't have evidence. Right? So if you see this picture, you can understand why it's impossible for doctors to predict outcomes. But it is something we want to solve with AI. Because AI, we think, and especially in the combination of health data was just explained, we want to collect data on a global scale, and I'll talk about that tomorrow. We want to use AI to make sense out of the data, to then do something else in the next patient, see what happens, and have that circle running in every hospital in the world, rather than just relying on what we do now. So that is the rationale for us to do AI. It is not because technology was there, but because we have a problem in medicine about predicting outcomes. Right? That's how we started, at least. Okay. So how do you go, as also an introductory lecture, I'll try to explain a typical example of how do you go from data, from health data, to an AI. And there's a certain method which everyone in the world is taking. So you start with an hypothesis, like, I want to predict survival of lung cancer patients, which are the example that I mentioned. Then the first thing you do is you sit down with your physicians and your domain experts and you talk about, okay, what do you think determines survival of lung cancer? And they might say, well, the size of the tumor, whether it's metastasized, what the age of the patient is, the general condition, right, and perhaps mutations, all the stuff that they think are important. Then you start, getting the data and polishing up, and there's a lot of work there. And then this is crucial, you split the data. You split the data into a training set and a validation set. And this is important because a model, an AI, will always work in the data on which it was trained. But that's not the question. You want to apply AI in a new patient. And so your question is the AI working in a patient it has not yet seen? Right? So that's why you do this split. So in the training set, you select of these perhaps 30 features, you select the 5 really important ones, you combine them in a formula, and there are many ways to do it, and then you have a model. And if you have a model, you take your validation set and you do performance validation, like an AUC calculation. So you calculate then in data that the AI has not seen whether it works or not. That's your general thing. An example here from CMC Vellore, working with Hannah on that, is so you have some data from us, from you here. This is about imaging, head and neck cancer, and we're trying to extract from the tumor in the head and neck whether or not there are features there that might be predictive of local control. And so you have an hypothesis, you have your image data, you start extracting those features from the imaging. It's a process called radiomics. You select which one are really important, you combine them in the formula, and then you validate them, right? So this is typically, a few of these sets are training sets and a few are validation sets. So that's a very standardized approach. Now, there is something new on the market for for let's say a decade now, which I need to explain as well, because it did change life a little bit and changed also this pipeline. So typically, to explain it, we had an image or a data set. We had a human thinking about what is important in this data. You had a model that combined those features, and then you had that the AI said, this is a car or not a car, right? This is similar to this, right? So do you see here a cat? And so if it had ears and eyes and fur and paws and a tail, if it finds that in the image, then we call it a cat, right? Now, so you have those 5 data elements from the image, but if you use this image, right, it also has all of those, but it's not a cat, it's a dog, right? So now you have to add features to that image, right? You have to think about, as an expert, okay, what differentiates a dog from a cat? And you may think that this is easy, but this is the typical example to show you that it's not. It's actually quite hard as a human to say what distinguishes a blueberry muffin from a Chihuahua dog. Right? So you're limited. And so the main thing in AI that's been happening that we are, besides classical machine learning, handcrafted machine learning, that's this part, we nowadays also do a lot of deep learning. And deep learning, the main difference is that this human step of human thinking, what is important in the data, is taken out. This has consequences, right? The fact that you have a human here also means you can input some domain expertise, right? Here, the computer decides for itself, and it becomes a black box. So if you compare humans making a decision like, who will live or who will be alive or not at 2 years, versus rule-based algorithms, which are rules, decision trees, perhaps you know these, towards more advanced to deep learning, the comprehensibility of the AI becomes less. And you have to be careful, because if you don't understand how the AI is working, it becomes quite tricky to apply it, especially in medicine, where you're going to make decisions based on AI, which can be quite dangerous. But the performance of deep learning generally is higher than these, let's say, classical machine learning. So there is a balance here. For some applications, deep learning may be a good choice, for some not, and it depends on what do you really need: comprehensibility, transparency, or do you need raw performance, right? And so that's an important thing to consider. Okay. As a general introduction, I gave you some concept. Now I'm going to talk to a few examples, especially also with our Indian colleagues and friends, to show you some of how this is applied in practice, some examples. So when you think about AI for healthcare, there are two main application areas. One is AI for better processes. That means automation, efficiency, right? Speeding things up, doing things, routine things that humans now do, but now doing it with the computer. You may think that this is a bad thing, but it's crucial. You know, I know you are resource limited. You know, I come from a country which, of course, is very highly resourced, but still we face this crisis that in 2035, the projections are in the Netherlands that 1 in 4 people will work in healthcare. That is unsustainable as a society, right? So we need to automate healthcare to make it sustainable. So better processes are important. But of course, if you follow my rationale, what I'm really interested in is AI for better outcomes, right? Can we predict outcomes for different therapies? Can I then select what therapy will work in this specific patient? And I'll give examples of both. Let's start with better processes. One of the things that is happening in medicine, so while we're digitalizing everything, it also means that we're typing a lot of things and dictating a lot of things. But it also means we're producing a lot of free text. And free text nowadays can be quite well analyzed by natural language processing. So what natural language processing, and I'm sure you heard about the ChatGPT thing, which are these new language models, they are very good at analyzing large amounts of text and creating structure out of that data, right? And this is important for efficiency, right? Because if I get a letter sent from a referring hospital, or if a patient is talking to me, if I can then record that conversation, have an AI look through what is being said, I can create structured data. In this case, from a radiology report, we can find this is the size of the tumor, this is the stage, and it's important, right, to have structured data for AI downstream. So this kind of saves time and annotation, and we're working with Tata in 2 PhD students on their corpus in Mumbai to do such things. Another major application area of AI is image-based analysis, right? And there's lots of AIs that are radiology or radiation oncology, my own field, pathology coming in, that are speeding up things. These are some examples. In radiation oncology, we have to delineate every normal tissue in the body. This can now be automated. That saves a lot of time to delineate. This is breast cancer screening. This is now equally or better than radiologists, the AI. And it's interesting, AI makes different mistakes. Huh? This is a breast cancer that the AI said is breast cancer, but 5 radiologists said was not breast cancer, and the AI was right, it was breast cancer. In this case, it was the other way around, right? 5, the AI said this is not breast cancer, and 5 radiologists said it was breast cancer, and the radiologist was right. So AI makes different mistakes from humans. That's important to realize. So AI is not intelligent in that sense. It only, it is different than us. And the application in digital pathology are also there. Is an AI going to be perfect? No. And the problem is that AI is only as good as the data that it saw, right? So this is a liver delineating algorithm from MD Anderson. The red is the AI, I think the blue is the human. And this was trained on CT scans with patients that were lying on their back in the scan, only. If you give this AI a patient which is lying on their belly, it starts making mistakes. It starts missing a part of the liver over here. Right? This is a mistake that humans will never make, but an AI does. Because an AI was trained on people on their back, and you can't assume that it will work with people on their front. Right? Important to know. AI is not intelligent. if you give this AI a brain scan, it will draw a liver, right? Because it was meant to do that. So this requires also some thinking. How do you introduce those AI devices? And one of our PhD students, Geeta from Philips in Bangalore, she was named one of the 21 women in 21. AI, so she finished her PhD at Maastricht with us. She has made, in one of her papers, which is highly cited, talks about that stuff, right? How do you accept, commission, QA AI devices and decision support systems to prevent such errors from happening? And you need to think about that. Another, besides better processes, we want better outcomes. And this is an example from my own clinic. What we're trying to do here is patients have chronic heart failure, they're at home, and if you have chronic heart failure, you sometimes become fluid overloaded, right? So your heart starts working less, your fluid levels go up, and then you have to take diuretics to get the fluids out of your body, otherwise your heart will fail and you will be in the hospital hospitalized, and there's a risk of death even in this disease. However, if you keep taking diuretics, your kidneys will fail. So there's this balance that you need to take. Do I need the diuretics? Oh, sorry, is my kidney failing? And we're trying to do this that people can do this themselves, right? So that rather than every time going into hospital and asking the doctor, do I need to up or go down in my diuretics or keep the same level, we're trying to make an AI or an app that patients can do this themselves, right? This is better for patients, less hospitalized, it's better for healthcare, less patients coming into your clinic, but of course this is quite risky, because if you make a mistake, that can have severe consequences. But as an example, this is what we're doing. Another of our students from India is doing AI for breast cancer, early detection and screening, right? In the Netherlands, we are a very small country, very highly populated, very rich, obviously. We do this with mammograms. But in India, in the Indian setting, you can't have an X-ray machine in every corner of this lovely country. So they're trying to make another less costly alternative to breast cancer screening, and to do this with infrared pictures, right? So a woman sits down alone as well, so that's also important for shame and things like that. In a tent, they can make a picture with a camera of their breast, and then an AI will look at the temperature differences between those breasts, and it can find tumors, because tumors are generally slightly higher in temperature than the normal breast. But that's, you need a lot of AI for that to process that, because you don't have doctors, right, in all rural areas in India looking at these pictures, and it's actually quite hard to do. So in the end, you get pictures like this, where you compare the two breasts, and you see a slightly higher region. These are two different patients, and you can say, well, this patient likely has breast cancer, and then you refer to the hospital. So this was done by Sivateya, one of the, he got the Forbes 30 Under 30 award this year. So one of our PhD students who finished at Maastricht, and he's now involved with this near-my company, which is trying to get this in India into the market, and actually has now gotten FDA approval, I think, for this technology. So this is very much high-end deep learning with very clear applications to improve outcomes. Another type of AI, more preventive AI. So this is work that we did with Apollo. And the thing is that we do have lots of models like Framingham that can calculate the risk score of cardiac disease, right, based on a lot of features. However, they are based on American data. Framingham is a city, right, in America. And so what Apollo found is that if they apply that in the Indian population, it really didn't work well. So what they did is they built a new one, which has typical Indian things like tobacco chewing, which obviously they don't do in the States. But also the fact that you have so many vegetarians here, the diet is also something that Framingham never considered, because, in Americans, they are generally not vegetarian. So they made this new AI, and they trained it in Apollo Delhi. And you can see AUCs here, which are quite high, right? So it's quite well done. What we did in Maastricht is we validated their model in Maastricht. And what you would see then, if an AI is learned on Indian data, it will work in India quite well. If we then transfer it to the Netherlands, to Europe, it works less well, but actually it worked better than the Framingham, right? So You can, I think, make models which are better when working together, and you can validate each other's models and try to find out what is working or what's not. And the reason, of course, it doesn't work in the Netherlands because we don't know diet, right? We don't know tobacco chewing, and so there are lots of things missing actually in our data to validate it properly. But the key message is, if you want to have good AIs, you have to base them on your own data and validate in your own country, in your own setting. As a final example, and the most extreme that we do, is using AI to actually decide on treatments. Right? This is proton therapy. And proton therapy, what it does is, if you would have a brain cancer and you would irradiate them now with photons, with classical radiotherapy, it would look like this. So your photons don't stop, but your whole piece of this brain is irradiated. This yellow bit is irradiated, right? Which can cause toxicities and bad things, obviously. Protons, they stop, so you only irradiate this, and this whole part of the brain is no longer irradiated. You may think, oh, this is going to be better in every patient, right? Because you don't irradiate a part of the brain. It is true, but only if there's an important part of your brain there. If it is not an important part, it doesn't really matter, right? Which of the two. And this is what we're facing. So we have about 3 proton centers in the Netherlands. We have 1,600 slots, so 1,600 people can be treated every year. And we have 50,000 patients that want this. How do we decide who gets it? We set and it's 5 times as expensive, and we don't have RCT evidence. Right? So in the beginning, we said from the start in the Netherlands, we are not going to have doctors decide this, because doctors cannot predict outcomes. What we're going to do is have an AI predict the outcome of this treatment, in terms of, for instance, cognitive toxicity, the outcome of that treatment, and then the AI says yes or no in my country now. So that means if you come into a hospital, an AI is checking what will be your toxicities with normal radiotherapy, what will be your toxicities with proton, and only if the AI says yes, are you allowed to be treated in my country. If the AI says no, we are by law forbidden to treat you, even if you bring €1 million. Right? It's not allowed. And this is now being validated in Apollo Chennai, where they also have proton therapy, because also you want to have a rational choice for new therapies and very expensive therapies like this, and you want to be able to use AI to select the patients that really need it. So my key messages for this starting talk is that we need AI. We need AI to improve efficiency in healthcare, but also to support decisions, right? Because humans are limited in their cognitive capacity to do these kinds of things, and AIs can help us there. We do have to consider this trade-off, whereas some AIs, like for instance automatic delineation of where the lung is or automatic mammograms, these are things that are done by black box deep learning algorithms. Why? Because you can have a human check the answer. Whereas if you make AIs for outcome prediction, if you say this patient will benefit from proton therapy because that patient will have less toxicity over a year, you only know the answer over a year. So you can't check it. So then it has to be very transparent, your AI. And there's this balance between that. Okay? But also what's important is validation. You have to validate an AI not just as a scientist, right? We do this scientifically. But also if you get an AI from a company, you have to validate in your own hospital, in your own setting, because we know that things are different, for instance, here in India, than in Europe, and you have to make sure that the AI works in your hospital and setting, and also keeps working as time goes on, because patients may change and the AI may change. So it needs a different kind of thinking. With that, I hopefully gave an introductory talk also for the rest of the conference, giving you some general concepts about AI and health data. Thank you for listening, and we'll see each other back tomorrow.
Thanks, Professor Andre, for that brilliant overview of health and AI. I'm sure there will be questions from the audience. Are there any questions? We'll take questions. Can you come forward to the mics and ask your question? Introduce yourself. Okay, I'll start with the first question. Given the potential of AI in medicine, we need a lot more people involved in using AI to answer all these questions. In every single disease, most diseases we can probably apply it in some way or the other. Do you think it'll help to introduce AI into medical education? If you sensitize doctors to this, will it help?
Definitely. I think it's when I give this talk also to the residents at Maastricht, at my university, the first thing they complain is, why are we only hearing this now, right? Why don't we get this earlier in our medical, because we know AI is coming, they understand, right? Young people understand the value of that, but they don't get it at all during their education now. And some see it as a possible risk to them, right? So I've just trained as a radiologist, now AI will take over my job. That is nonsense, by the way, but I can go into detail there, right? It's never going to happen. And just because of those fears, I think you also, if you know AI well, you also know its limits, right? You know what strengths are, and you can benefit as a physician, as a nurse, as a patient even from AI. So I think education early on is very difficult, very important. But we are retraining our doctors now as we speak in AI at Maastricht, just to get them tuned.
Are there any textbooks on AI in medicine?
There are certainly, but there are, I think, what is especially coming up is MOOCs, right? Massive online educational lectures. So there's for my country, but many others, they have introductory courses to AI for doctors and then advanced courses. So they are really, really good at the moment. So I think AI shouldn't be taught from a book, but should be taught from AI, from computers.
Thank you.
Check. My name is Blessed, and I'm a pharmacologist. I do some PK modeling. And I had this question on deep learning. So you said the feature extraction is done by, I understood it, in my naive understanding that it's automatic.
Yeah.
So
correct.
Do you get to know what are the features which are selected, and you can go back and do in a machine learning kind of way, put in, take out something, or?
You can, but it's not very valuable because the features that it extracts are ununderstandable, right? So you can open a little bit the black box. If you do deep learning on images, you can at least ask the question, things like, which part of the image are you looking at? And you can also indeed extract the features that it gets from the image, but these features are typically nonsensical. So you can't really comprehend what they mean. So the honest answer is, if you want to have explainable AI, then probably deep learning is not the right approach.
Okay, thank you.
Can you hear me?
Yeah?
Yeah. Good morning. Hey, I'm Nitin. I work on AI with Goldman Sachs. So I kind of do AI for traders to come up with trades that make money. So it's actually very difficult convincing them on, do exactly this, because their job is to make money, and me getting in there and telling them what to do is very different. And when I use deep learning models, again, as I said, it's a black box. You don't know why you're trading it. Say you make money or you lose money, you are answerable to your clients, right? So it's something very, very similar here as well, right? So you come up with a model, but you will also have a human who's going to look at it. So when you mentioned the last outcome, in your journey in Netherlands, how were you able to convince either the government or the university to collect data and then work on the model? And then how was the journey of convincing the doctors to actually care about it? Because it's a collaborative thing.
Right.
Nobody can work alone. Like as a
Totally.
AI person, I can't work alone without the help of doctors, right?
Yeah.
So how was the journey?
Yeah, that's a very good question. So, so in the proton therapy case, what we did is we first of all, you have to start with models which don't include any proton therapy data because you don't have that when you start it, right? So it's also a chicken and egg thing. So you actually start with more photon, classical radiotherapy models, knowledge-based models. That's your starting point. And then the government, in our permit for proton therapy, forces us to collect all data on proton therapy patients and update the models every year, we're thinking now, right? With the idea is that only when you have data and you're forcing people to have data, can you update the model and then make them become better and also follow practice, right? So it is actually a systematic approach where we're getting paid to collect data as proton centers, but we're also forced to work with data scientists to update the models, and health insurance companies have to accept those updates. And so it is indeed a systemic approach because you cannot do this alone. You're absolutely right.
Hi, myself Gerald Napoleon from Grapes Innovative Solutions. We are providing digitalization from last 17 years. We are facing one problem in India. For doing this kind of data analytics job, because across India, in our client hospital, if they are using electronic medical records, there is no standard keywords or something like that to take decisions or writing the decision in electronic medical records. Then, in this scenario in India, how we can do we can trust on the data for doing these kind of evaluations to make an evidence-based decision-making supporting system. It's a scattered data architecture used across India. Then how any kind of solution you find in between your studies, sir?
Yeah. So I think it's a question about data quality and the long-term garbage in, garbage out problem. How can you learn from data if your quality is uncertain and if it's low? Let me first of all say that the situation in India is not so different from the situation in the Netherlands, right? You would assume that we have great quality data. We do not, right? You would assume that we have excellent standardized recording of elements. We do not, right? So the situation is not better in my country. So we're facing the same thing. To be honest, the approach is typically to just get started already, right? You have some data elements which you know are pretty good, right? And you can perhaps collect by hand or otherwise some other high quality data, and you start your journey, right? And what we always see is when we start a journey using data for AI, then suddenly the quality of data becomes important to a hospital or doctor because they now know the AI needs it and they will know it will be updated. So you have actually a virtuous circle where data is being used, and then people are more willing to record high quality data because they know it's being used. And then suddenly you are in this upward spiral, right? But you have to start already. Don't wait for data quality to be perfect because it will never happen.
Thanks a lot, Andre.